Greetings. Let us learn about altered surgical anatomy, in this case, Billroth II gastrectomy. You can see Billroth II gastrectomy anatomy here, and let me take you through step by step how this Billroth II gastrectomy is performed. So let us look at normal anatomy: esophagus, stomach, antrum, duodenum. In Billroth II gastrectomy, this is the portion of the stomach that is resected, and once the resection is completed, the duodenal stump is closed and the gastrojejunostomy should be created next. You take a loop of jejunum and anastomose to the stomach, creating gastrojejunal anastomosis. In Billroth II gastrectomy, there is gastrectomy followed by closure of the duodenal stump and a gastrojejunal anastomosis. And when you want to perform an ERCP and you know that the patient had undergone gastric surgery, it's important to figure out what type of anastomosis does this patient have. If it's Billroth I, like we have seen in the previous video, you don't have to worry. You follow the regular path and you reach the ampulla, from the stomach to the duodenum and to the ampulla. In Billroth II, from the stomach, you need to get into the jejunal loop, figure out whether it is an afferent loop or an efferent loop. Afferent loop is the one that is draining from the pancreas and the bile duct to the stomach, and efferent loop is going away from the stomach down to the distal jejunum and ileum. So it's important to get into the afferent loop. And then you need to make sure that the afferent loop limb length is not too long. If it is too long, you may have trouble reaching the ampulla. So let us look at the pathway that the scope takes. So here, esophagus, stomach, anastomosis, afferent limb to the ampulla. Usually for this procedure, endoscopists typically use a colonoscope or in some cases a therapeutic EGD scope. Going with a side viewing scope may be technically challenging and something to keep in mind. So once you reach the ampulla with an endoscope, forward viewing endoscope, it is important to actually have a cap at the end of the scope so that the cap could actually press on the folds and make the ampulla accessible for cannulation and subsequent cholangiogram. So, as you can see here, the anatomy of the Billroth II. You have the stomach, the distal portion of the stomach has been removed, the duodenal limb has been closed, and the gastrojejunostomy has been created, and you have an afferent limb and an efferent limb. Afferent for AFF, E-R-E-N-T, afferent limb is the one that you take to reach the ampulla. I hope this is useful. Thank you.